that I was explaining here, we just did the anterior and posterior chest assessment. Now we're going to do the abdominal assessment, and it's most comfortable for the patient and more beneficial for you to have the patient lay down supine for this portion of the assessment. I'm here first. Again, this is going to be without the gown, but I'm inspecting from mid-chest to pubis for symmetry, color, scars, lesions, peristalsis, pulsations, and bulges. The order for assessment on the abdomen is a little bit different. So first, you're going to inspect as always, but then we're going to auscultate second, and then we're going to palpate. Because if you palpate before auscultation, you can sort of create peristalsis with your palpation, and you don't want to create peristalsis. You really want to hear what's intrinsically happening with your patient. So we're going to inspect, auscultate, and then palpate with the abdomen. So I've just inspected. Now I'm going to auscultate. Again, you're going to use the diaphragm of your stethoscope, and we're going to be listening for bowel sounds. You can start anywhere you want. You just want to make sure you assess all four quadrants. So I usually start with the right lower quadrant, moving up to the right upper quadrant, and then over to the left upper quadrant, and then down to the left lower quadrant. That way I make sure I assess all four quadrants. You want to hear a bowel sound every 5 to 15 seconds. You want to hear some sort of gurgle, some sort of sound. If you hear it more frequently than every 5 seconds, we would say that's probably hyperactive. And then if you hear it less than 15 seconds, we would say it's hypoactive. If you're listening to a quadrant and you do not hear any sounds in 5 minutes, and 5 minutes is a long time to listen, but we have to listen for a full 5 minutes, we would say that's absent. If we have absent bowel sounds, we would need to contact the provider and let them know, because that could be a sign of an obstruction or an ileus of some sort. So that would be concerning. And that would be accompanied with other symptoms as well, like distension, discomfort, but we just want to make sure we let the provider know. Now that we've auscultated, now we can palpate the abdomen. And first we do so very, very lightly because we want to make sure that there's no tenderness. A lot of times in the abdomen there can be tender spots depending on what the patient came in for. So we want to watch for what I was showing there was guarding. We want to watch for guarding. If they wince, you can watch for facial expressions, tenderness. After light palpation, we can go into a deeper palpation in certain areas as well. So we're palpating all the quadrants. We're palpating the bladder for any tenderness, guarding, masses. And then when you're going to show us how you're going to palpate for the inguinal region, like the inguinal lymph nodes and the femoral pulse, you can show that to us on yourself. So here I'm showing the inguinal lymph nodes and then the femoral pulse.